Good morning. We start off the session. The first presenter there, Dr. Shivangi Singh. Yeah, please. You have 4 minutes for the presentation. Yeah, you can start, ma'am.
Good morning, everyone. The topic of my presentation is modified technique of using capsular tension ring in various degrees of subluxated lens. So starting with the introduction, the older technique used to be difficult. It used to cause damage to the posterior capsule or posterior dislocation of CTR and IVL and escape of ring in the anterior chamber, rupture of anterior capsule, or maybe extension of the subluxation. So we performed a prospective interventional consecutive case series of 29 eyes of 29 patients, and subluxated cataract up to 270 degree was included in our study, while more than 270 degree of subluxation, cases of active uveitis, corneal opacity, scleral thinning, open globe injury and retinal detachment cases were excluded from our study. Coming to the result, in our patient age group of less than 30 years were 17 patients, and between 40 to 50 age group there were 8 patients, and between 50 to 60 years there were 4 patients. In 10 patients, subluxation was less than 90 degree. In 15 cases, subluxation was between 90 to 180 degree. And in 4 cases, subluxation was between 180 to 270 degrees. And standard CTR was used in 12 cases. CUNY with a single eyelid was used in 10 cases. And CUNY with double eyelid was used in 7 cases. So for scleral fixation of a CUNY ring, firstly we bent the straight needle of double arm 10-0 polypropylene and made it curved as a modification. Another modification made by us was the use of bent curved 26 gauge needle to fetch the bent curved needle of 10-0 polypropylene suture outside the eye. The advantage of using this bent curve 26 gauge needle is that it keeps the direction of the needle tip upwards during the passage through the scleral bed into the anterior chamber so that the chances of piercing and damaging the capsular bag is very unlikely. Secondly, feeding of bent curve 10-0 needle into a bent curve 26 gauge needle becomes much easier compared to the straight needle, as shown in this diagram. So to conclude, the advantage of a modified technique is that it prevents the inadvertent escape of endocapsular ring out of the bag in the sulcus. Secondly, it avoids any stress on the anterior capsular margin, thereby preventing tear and extension of rhexis margin. Thirdly, it changes the vector force from vertically anterior-posterior to horizontally along the capsular bag, thereby reducing stress on the existing intact zonules, preventing the posterior dislocation of the capsular bag CTR complex into the vitreous cavity. Thank you.
In spite of these precautions, did you have any adverse effects in your series?
Not in these cases, sir.
No, did you? How long did you follow up these cases? Do you have follow up of these cases?
So we have a follow-up of these cases, but it was not included in our study, the follow-up.
You used 10-0 or 9-0 problem?
As a 10-0.
Do you believe that this 10-0 will hold on for long?
So right now we have followed up these patients for at least 1 year, but no subluxation has been noted in these cases, sir, yet.
So just for your info, 9-0 will hold more,
Yeah.
and now this our Gore-Tex is available, which will hold on for good.
Oh.
Thank you.
Okay. Thank you.
Dr. Paulami Ghosh is there.
Hello, good morning. Good morning. Good morning.
Let's start marking for the second.
Yeah. Just kidding.
Come.
Good morning. The topic is effect of size and shape of NDR capsulotomy on visual acuity and IOP in patients with Pearl type PCO. I have no financial disclosures to make. Now, the incidence of PCO after an traumatic cataract surgery was between 5 to 50%, and after 5 years, it was found to be more than 25%. So, NDAG was found to be a very effective method to deal with it. Now, an ideal capsulotomy size, as the literature says, should be equal to or exceed the pupillary diameter in dark, while remaining within the border of the intraocular lens. Two common shapes of posterior capsulotomy openings have been studied, which is the cruciate and the circular. However, not many studies exist comparing different capsulotomy techniques. Now, our aim was to find out whether the size and shape of NDR capsulotomy has any effect over post-laser visual acuity, IOP, and complications in pseudophakic patients with grade 4 Pearl type posterior capsular opacification. After thorough IC approval, a prospective observational study of 100 eyes and 80 patients with grade 4 Pearl type PCO was taken for our study. After 1 month post laser, we divided them into 4 groups. Group A, circular shape less than 3.5 mm. B, more than 3.5 mm, similar circular shape. C was cruciate less than 3.5, and D was cruciate more than 3.5 mm opening. We found that in 100 eyes, we divided the patients into 25 groups of each, 45 male, 35 female, 60 with unilateral PCO, 20 with bilateral. Average age was between 44 to 84 years. In our results, we found there was no significant difference between the BCVA and the IOP 1 month post pre and post laser comparison. However, there was a significant difference found between the number of laser shot firings and the total energy requirement between all the 4 groups. In pair-wise comparison, there was a significant difference found between the circular shape of less than 3.5 mm and cruciate more than 3.5 mm. In total energy pair-wise comparison, also we found a significant difference between the circular shape with less than 3.5 and cruciate, which was more than 3.5. Rate of floaters was the highest in group D, which was cruciate shaped capsulotomy with more than 3.5 mm. Now, the previous studies have shown that a large capsulotomy helped in better posterior segment examination, however, was associated with complications and hyperopic shift. And in terms of capsulotomy shape, studies have shown that circular shape had more floaters and macular edema as compared to cruciate with more light scattering. In our study, we did not find any significant difference between the BCVA and IOP in either this different types of capsulotomy sizes and shapes. However, in terms of shots and energy, the shape of with size, which was less than 3.5 mm, fared much better and required lesser shots and energy, and the circular shape required much lesser shots and energy. In terms of floaters, the larger the capsulotomy size, more incidence of floaters was noted, and the cruciate shape was associated with more floaters. However, we had the limitations of a small sample size and short follow-up and assessment of a fewer parameters. In conclusion, I would like to say that both circular and cruciate shaped capsulotomies were found to be comparable. However, less than 3.5 mm capsulotomy required the least number of shots and energy with similar visual outcome as the larger size. And smaller capsulotomy was associated with lesser complications as well. Thank you.
So follow me. How did you measure the size of the capsulotomy? Did you like document with photographs? And also, when you say more than 3.5, like what size is it? That's a very vague number.
Slit lamp reticule was used for the measurement post after 1 month of the capsulotomies, and all of those which in the reticule were coming as more than 3.5 but within the pupillary scotopic margins were approximately taken. Dilated measurement was done though.
This was done at 1 month.
Post 1 month of the capsulotomy, and then they were divided into the different groups.
All patients were dilated before a capsulotomy, or it was?
Yes, sir. We did perform dilated capsulotomies.
Was there any higher instance of post-YAG CME as come in the 2 groups?
So that was our flaw. Actually, we did not measure the CME post. Yeah, that was one of the parameters which was not measured.
And did you measure the undilated pupil size of these patients?
Yes, sir. An average undilated pupil size.
You should have mentioned it here.
Yes, sir.
Thank you.
Thank you.
The next presenter, Dr. Kusumita. Is she there? Dr. Surya Shekhar Das.
Absent?
Dr. Deshpande.
Good morning, everyone. I'm Dr. Vijay Shetty. I'm speaking on behalf of Dr. Nitin Deshpande as he is not able to come. So the paper is astigmatic changes of intrastromal relaxing incision performed during femtosecond cataract surgery. Femtolaser assisted cataract surgery involves use of femtosecond assisted construction of corneal incision, capsular excess, and lens fragmentation. Rest of the steps are completed using standard phacoemulsification procedure. In addition, femtosecond laser is capable of performing intrastromal relaxing incision for correction of smaller astigmatism. Commercially available femtosecond laser platforms include LensX, Catalyst, Lensar, Victus, and FemtoLDV. All these systems use the same solid-state femtosecond laser with a pulse duration in the femtosecond range. The imaging system in Lensar platform is Scheimpflug imaging technology, whereas in other machines use spectral luminosity. These are the unique features of the Lensar system on which we have made a study. Femtosecond laser allows a precise placement of arcade keratotomy incision in patients undergoing FLACS. So the factors affecting outcome of FSAK include type of preoperative astigmatism, eccentricity of the cornea on topography, biomechanical properties of the cornea, and arcuate incision characteristics. So aim of our study was to study the visual and refractive outcomes in patients who have undergone femtosecond laser assisted arcade keratotomy with FLACS. And secondly, to study the refractive efficacy of FSAK and factors affecting refractive efficacy of FSAK. The patients between ages of 40 to 90 years with an preoperative astigmatism of 0.5 to 1.5 diopters were included in the study. Patients with corneal pathology and previous ocular surgery were excluded from the study. Astigmatic measurements by keratometry was made by Sirius topography and IOLMaster 700. Nickman-Woodcock nomogram was used for arcuate incisions. These are the preoperative data that were collected. We also calculated the efficacy of arcuate keratotomy using the formula 1 minus postoperative cylinder divided by preoperative cylinder into 100. So standard statistical methods were used for analysis. Nearly 50% of the patients were between 60 to 69 years, and equal distribution was seen in male and female population as well as the laterality of the eye. The median corrected distance visual acuity was 6.6. Both uncorrected as well as distance corrected visual acuity was similar. So this shows that like the FSAK worked really well. Median preoperative cylinder was 0.61 diopter and median postoperative cylinder was 0. So again with a significant p-value. 70% of the patients had a residual cylinder less than 0.25 diopters. 90% of the patients had residual cylinder less than 0.5 diopters. Only 10% of the patients had residual cylinder greater than 0.5 diopters. Patients with residual postoperative cylinder greater than 0.5 diopter had a preoperative astigmatism, had a larger preoperative astigmatism, and a larger arc length was used. So higher percentage of patients with refractive efficacy less than 100% were seen in patients with preoperative against the rule astigmatism. So in a subset of patients with refractive efficacy lesser than 100%, mean eccentricity value was lower compared to subgroup with refractive efficacy of 100%, suggesting lower eccentricity value was associated with suboptimal outcome of FSAK. So to the best of our knowledge, this is one of the first studies using Nickman-Woodcock nomogram on Lensar platform. The results show that FSAK significantly reduced preoperative astigmatism with high proportion of eyes had a postoperative cylinder of 0 to 0.25 diopters. Postoperative uncorrected visual acuity was similar to best corrected
Time
visual
over,
acuity.
please.
To conclude, FSAK is a reliable method to reduce preoperative corneal astigmatism. The factors associated with less than 100% postoperative efficacy include higher preoperative cylinder, lower eccentricity value of cornea and against the rule astigmatism. Thank you.
Just to you are losing marks if you don't stop on time. We are supposed to mark you less if you don't stop on time.
Yeah, Vijay, so what is your inclusion criteria? I don't think that was clear. How much astigmatism is there?
0.5 to 1.5 diopters.
1.5. You're stopping at 1.5.
Yes.
And beyond that, you're going for a toric IOL.
Toric IOL.
90% of your patients had up to 0.5 residual.
Pardon?
90% of your patients had up to 0.5 of residual cylinder. Is it not?
Yeah, less than 0.5 diopters.
And how long do you have follow up on this?
We have follow-up up to 6 months.
6 months. 6 months is not so very enough for these cruciate incisions to
Yeah, there may
relax
be
and
regression
then regress
later
back.
on.
And you have selected from 0.5 to 1.5
Right.
and 90% are still have 0.5.
Yeah, because some of the this is a median actually.
Thank you.
So it's a fair study. Like we do a lot of LRIs on femto, and the results are not predictable. We've tried various combinations, and they do not even last very long. Hence, the predictability in nomograms are difficult. So even if your conclusion is that it doesn't work in more cases or doesn't stay long, that's fair. I mean, a study is to establish that part, but probably just a longer duration. Maybe you can do a more follow-up. Will make it more concrete. What was the result at the end of the 1 year? Because the effect of arcuate do wear off
Yes.
over a period of time. So, but good effort.
Yeah. Thank you.
Dr. Kanika, can you switch off those bright lights? Yes, start, ma'am.
Okay, good morning everyone. So today I'm here to present an interesting case. I'm Dr. Kanika, I'm from Center for Sight, New Delhi. So this is a case of iridoskisis with angle closure glaucoma and cataract that came to our clinic, and the surgical management of the patient is being described. So it's a rare disease in which there is a splitting of iris tissue into anterior and posterior layers. Most of the time people are not able to recognize this disease, as they term it as iris atrophy or even floppy iris syndrome. There are multiple tricks to tackle the condition intraoperatively. We will be describing our technique. So it was a 70-year-old male patient who came to our clinic with diminution of vision, pain, redness in his right eye since 1 week. Elsewhere, he was being treated on 4 anti-glaucoma drugs and had even undergone undergone laser iridotomies, which were patent. His pressures in the right eye were, despite of all the medication, around 40 millimeters of mercury. The left eye was not so bad with a 0.7 cup. The right eye also had advanced glaucomatous cupping. He had cataract. After looking at his situation, we decided let's go on with the combined phacoemulsification and trabeculectomy, though it is a very big challenge. So please notice here the presence of frayed iris tissue. This is the iridoskisis, where the anterior layer splits and is more interfering in the anterior segment. The patient had cataract. On UBM also we can see the splitting of the iris layers. So what we did was we did a superior temporal bleb fashioning and superior phacoemulsification incision. Both the sites were kept separate. I would directly go ahead to the video. So this is the patient. A bleb is being fashioned. Please notice that the iris here is dilating well. So there is no sphincter atrophy as of now. The bleb being fashioned. Mitomycin was used. And here we are. Notice how well the iris is behaving at the initial procedure. Rhexis was completed. And here, now please notice how all hell breaks loose as this iris tissue decides to constantly come into the phaco probe at all times. So this was a nightmare. Of course, we tried to tackle it by keeping low fluidics. We also used a cohesive viscoelastic at multiple points during the surgery to keep the iris tissue in place. In fact, we could even use the irrigation probe in the bimanual aspiration to keep this iris separate. Many people also describe cutting off the tissue or even cauterizing it, but that would be too much of a damage. Please notice how the iris tissue keeps coming into the probe again and again. So this is what I was talking about, the surgical nightmare. It constantly interferes during the surgery. You have to keep low parameters in fluidics. The iris is floppy, of course, and it again interferes with the procedure. Anyhow, in this patient with patience, a lot of patience and a lot of skill, we finally were able to give him a good outcome post-op after doing a good phacoemulsification. Luckily for us, there was no zonular weakness, and after fashioning the bleb. So notice how the irrigation probe is keeping the iris tissue apart and letting it not come into the aspiration probe. This is one of the techniques that we can follow during the procedure. Monofocal lens being implanted, and the bleb being fashioned after iridectomy. So at the end, we sutured all the ports, and this was the post-op outcome. So for the patient, he did very well after surgery. His present vision best corrected is 6/9, of course with some refractive error,
Time
and
up,
near
please.
vision is
Dr. Kanika, do you not think that the iris hook or a Mulligan ring would have helped better in such cases?
Definitely, ma'am, but iris hook would have helped in a situation where we would have anticipated that the pupil is too small and maybe it will not. So pre-operatively, we were not able to determine the severity of the frayed tissue. It looked very stable during the pre-op examination on the slit lamp. We thought since it is restricted to the inferior quadrant, and maybe we would be able to manage it better. It was only during the procedure that we kept noticing that it is not sitting well.
So, difficult cases.
Yeah.
The whole idea is to have a backup while during the surgery.
Yeah.
So, if we were operating and you see the iris coming, at any point you can do the iris hook, and at any point you
Definitely,
can
ma'am,
put
but the
ring.
hook will not give a very good anchorage to the frayed tissue, which will try to escape and come out at every point. So, for our case, what I would like to say is that using a cohesive viscoelastic was a better option because it kept the iris tissue in place. Even applying 2 or 3 iris hooks in that direction would have not completely obscured the iris from coming into the probe as soon as the aspiration
So,
was
let me
on.
ask you again that if you have same difficulty again, would you want to take help
Definitely.
of hooks in future?
We did have
Would
it
you
as a
want to
backup.
give it a try?
Yeah, we did have it as a backup, but during the procedure, like the surgery was performed by my mentor, Dr. Sagarika Patyal. She's a very senior consultant in glaucoma cataract. So ma'am decided that instead of manipulating with the already atrophic iris tissue, it is better to keep a gentler approach, and that is why we did not go ahead and implant the iris hook. We tried to do it in a more gentle way so that post-operatively also we don't have much complications.
Sure, but it was a well managed case. Yeah.
And what was the pre-op IOP of this patient?
So pre-op IOP on 4 medications and with patent
On 4
iridotomy.
medication,
Yes.
on 4
He was
medication.
on bimatoprost, brimonidine, timolol, and dorzolamide. And in spite of that, his pressures were at 40 millimeters of mercury. A shot of mannitol IV that we gave only reduced it to around 36 millimeters of mercury.
You put many sutures in the side port also.
Yes, sir.
Why so?
So because during this procedure also the iris kept coming out and we did not want to take a risk.
But the iris was coming
post-operatively.
from the main port only, not from the side
We
ports.
do not take risks, sir. In all such cases, ma'am by default puts sutures in all the incisions. So to be on a safer side post-operatively, we don't want the patient to suddenly collapse the chamber during one of his maneuvers, cuffing or something, and let the iris again come out. So she sutures all her incisions.
Okay, thank you so much.
Thank you, sir.
The discussion part is fine, but I would have definitely used an iris hook when
Yes, sir.
required. When required.
required.
And nothing is. It is not so not gentle or anything like that. So this was more harsh on the iris, like pulling it through the phaco probe and all those. And whenever small strands come, I would snip that strand off rather than trying to hold it on to the phaco tip. And also, your incision was quite short. In such cases, we would make it larger and also come out of the anterior chamber without irrigation. Stopping irrigation. So at any point, I would use iris hooks to keep the iris away. Once, and also I will not tell that iris was always coming into this one. Iris is not something which will likely come into your section. It is because of our manipulation that it comes.
Yeah.
So to prevent it, it's our responsibility to keep it away from your port. Thank you.
Thank you, sir.
Dr. Tony Koshi.
Good morning, judges. This is an objective assessment of simulated surgical outcomes using the M6 virtual reality simulator in trainees posted for cataract surgery. So the virtual reality simulator is one of the training modalities along with animal eyeballs, cadaveric eyeballs, and inanimate objects. The virtual reality simulator first started in the aviation industry and have now crossed borders into the surgical subspecialties. It has also come into the ophthalmological specialties, including cornea, cataract, glaucoma, retina, and the orbit. So this was a retrospective study conducted between December 2021 to May 2022 in 10 subspecialty fellows who had less than 30 M6 experience with no prior experience in the VR simulator. So the modules in the VRS included the sclerocorneal tunnel construction, capsular access and nucleus delivery course, cortex removal and IOL implantation, and restoration of physical condition. They were assessed in their scleral groove, tunnel dissection, keratometry, capsular access, nucleus delivery, and IOL insertion. So the parameters assessed by the VRS included in the scleral groove, it was the length of the groove, the average depth of the groove, and the complications. Corneoscleral tunnel included the maximum length of the tunnel, the length of the inner tunnel limit, and the length of the tunnel as a whole, along with complications. Keratometry included the length of the inner tunnel opening, the length of cornea dissected, and the complications. Capsular access was the dimensions, the maximum and the minimum size, and the complications. Nucleus delivery and IOL implantation included complications. So coming to the results, the scleral groove, the maximum satisfactory score was 23 out of 30 by a candidate, and the minimum score was 7 out of 30. 9 out of 10 candidates had inadequate depth in more than their 20 attempts, with a mean satisfactory score of 3.1 plus or minus 4.17. In corneoscleral tunnel, the maximum satisfactory attempt was 21 out of 30, and the minimum was 0. Perforation and laceration of the outer wall were the more common complication, followed by uveal prolapse and premature entry. The mean satisfactory score was 6.8 plus or minus 5.75. In keratometry, the maximum number of satisfactory length of the inner tunnel opening was 13 and minimum was 1, and the maximum number of satisfactory length of the corneal distance from the limbus was 13. Endothelial touch followed by lens touch were more common complication, followed by laceration of the outer wall, buttonhole, premature entry, and iris contact. In the capsular access, the maximum number of satisfactory attempts was 25 and the minimum was 7, with zonular dialysis and capsular access runoff being the more common complication, and less commonly iris contact with endothelial touch was seen. The mean satisfactory score was 5.8 plus or minus 7.74. In the nucleus delivery, the complications were iris pull followed by endothelial touch, and IOL insertion, it was zonular dialysis. We also compared the first half of the attempts with the second half of the attempts, and we found that the second half was statistically significantly improving following their practice with the VRS simulator. So an ideal VRS will give the learners a virtual eye that looks and feels like a living eye, and the metrics used during their training is predictive of their actual performance performed during surgery on real patients. Studies by Ferris, J.D. et al. And Staropoli et al. Have shown that after the VRS simulator, the complication rates had drastically reduced. So in our study, we found that the sclerocorneal tunnel and keratometry, even though they were superior in their dimensional aspects, they were fraught with complexities and architectural issues, with perforation and laceration of the tunnel lip in corneoscleral dissection and endothelial touch during keratometry being more common. Similarly, the capsular access was good in their dimension, but they had complications resulting in a lower satisfactory score. So these informations had enabled the trainees to perform an architecturally correct tunnel and capsular access while mitigating the anticipated complications better during their live surgeries. Hence, a better understanding of the complications that were more prone to occur during the surgery were identified and rectified earlier by repeated practice and discussion. So to conclude, the relevance of VRS in this current scenario includes the ethical consideration towards the patient. It is a practicing and training tools for the surgeon. It gives an objective evaluation. It improves the architectural accuracy, and it reduces the complication rates. Thank you.
Thank you. I think it's a good presentation.
Thank you, sir.
System has an inbuilt scoring system, right? It's already, the VRS has already an inbuilt scoring system.
Yes, sir. We've taken the metrics from the scoring system.
Sorry?
We've taken all these metrics from the scoring system, sir.
On the scoring system.
Yes,
But nucleus delivery there's a nucleus delivery system.
Nucleus delivery, only the complications is analyzed, sir. They do not
Because
have...
that has usually for only phaco emulsification, right?
This is for the M6, sir. This is the Help Me See simulator, which is specifically designed for M6. Now they've come up with the phaco also, sir. Yes, sir.
Thank you.
You have a good recording system and all, no? For this, there?
Yes, sir. This
Well, not even one picture. You should have put some pictures, no, for us to see, because the simulator system is a very good system,
Yes.
which people cannot afford. Many people, institutes like yours will definitely afford. So people should learn this and know about this and come there to study.
Sure, sir.
Put picture next time.
Sure, sir.
Good. Thank you.
Thanks.
See, because this is for all the presenters and for future, because you see it's being judged on the presentation also. So it's not just the originality and content, but in presentation till the end, we didn't get a grasp of what was actually done, what's the simulator, what's the picture. So that's why we're discussing. So just for future, this thing,
Sure.
whenever you present, pictorial, because you have to get the attention of your audience in just those 4 minutes.
Yes.
So some pictures, some short videos, some animations help.
So, is it the same simulator which is used for phacoemulsification also?
No, sir. This is only for M6.
Only for SICS?
Yes, sir. They are now developing it for FACO also. It will probably release by June, July.
It is
I
written,
think.
not ratified. Okay, thank you. You are not ratified member, right?
No, ma'am. No,
So
sir.
it will not be judged. Thank you.
Dr. Supriya.
Good morning, everyone. My name is Dr. Supriya Sriganesh, and today our case is phaco with ICL situ in a case of high hyperopia. So phakic IOLs are a popular correction for high refractive errors in high myopia, hyperopia, where corneal procedures are unsuitable. A known complication following hyperopic ICL implantation is anterior subcapsular cataract. High refractive error, intraoperative trauma, inadequate vault, and advancing age contribute to this. In these cases, cataract extraction along with removal of ICL and implantation of PCIOL is usually performed. And among the third and fourth generation formulae, Haigis and Barrett Universal 2 showed better post-operative refractive results. So in our case, we present a 29-year-old male who underwent with counting finger 2 meter both eyes and corrected distance visual acuity of 20/40 with plus 13 in both eyes, underwent uneventful ICL implantation of 21 diopters in both eyes. His post-op uncorrected vision was 21/20 and corrected distance visual acuity is 20/40, and there was a residual refraction in both eyes of plus 4 and plus 4.5. 1 year after the surgery, he developed anterior subcapsular cataract in the left eye, and biometry using IOL Master 500 was done with a net IOL power of 47 diopters. At this point, the patient was not affordable, and there was no described method for calculating IOL power to be implanted while maintaining the ICL in situ. So a standard IOL of 22 diopters was placed, and a residual refraction of plus 3 diopters was there in the left eye. Now, 8 years after this, anterior subcapsular cataract was seen in the right eye also, and at this point we had the IOL Master 700 with Barrett Universal 2 formula with a net IOL power of plus 45 diopters. So a new method of IOL power calculation was devised. Basically, the initial refractive error was 13 diopters and the residual refractive error was plus 4. So the ICL has basically corrected only plus 9 diopters. Therefore, the target refraction should be plus 9. We kept to aim for a myopic astigmatism. We kept it as plus 9.5 and implanted this lens. This was the surgical technique where basically the two haptics of the ICL were tucked out and placed over the iris. The capsulotomy and the phacoaspiration IOL implantation was done under the ICL, and the haptics of the ICL were tucked back under the iris. This is the same biometry that I explained earlier, and the resulting IOL power that we got, keeping a target refraction of plus 9.5 diopters, was 30 diopters. So the 30 diopter lens was implanted instead of the 45 diopter lens. So you can see this is some of the patient information. Just note that the IOL power used in the right eye was 22 and in the left eye was 30, and the post-cataract surgery refraction in the left eye was just minus 0.75 cylinder compared to the right eye, which was plus 3. So just to discuss, the other methods that we could have used was to explant the IOL with cataract extraction, followed by implantation of a high-power custom IOL. This is more expensive, takes a special injector and a larger incision for a thicker lens. We could have explanted the ICL, followed by implantation of two IOLs, a primary piggyback, but complications like interlenticular opacification, PCO glaucoma are there. So this innovative technique was used. The advantages are that it's cost effective, it reduces endothelial damage because the ICL acts as a shield, and a unique biometric formula resulting in negligible residual refractive error. The drawbacks were that it's more surgically challenging and potential complications are damage to the ICL, zonular damage, and difficult in harder cataracts. Thank you very much.
Thank you for your presentation, but I still feel that it was a better option that you could have explanted the ICL and then put the intercroral lens, because it was of course difficult procedure, cannot be done by every surgeon. Expert people will be able to do it, and then there are chances of endothelial cell damage.
Yes, so that's one of the drawbacks. But this particular patient wasn't affordable for a customized high power IOL. So he initially, which is why this was almost performed 15 years ago, the first procedure, followed by 8 years ago, 8 years after that procedure, where the customized high powered IOLs were still very expensive at that point, and this particular patient was not affordable for that. So that's why this unique method was devised, and the surgery was uneventful and gave the patient in the left eye almost emmetropic vision. With the right eye had a +3 residue, but that was the reason why the new biometry was developed.
Just a point, no, this ICL is usually calculated based on the anterior chamber depth also.
Yes, sir.
Because post-op the anterior chamber depth is going to change a lot.
Yeah.
Because it's gonna
Preoperatively, the anterior chamber depth was
was it considered in your formula which you said?
basically, sir, the formula was to see how much the ICL was already correcting. This wasn't a dense cataract. There was not any nuclear sclerosis. It was an anterior subcapsular cataract.
Basically, it will be not predictable in all the cases.
Yes, sir. In this particular case, it worked. But normally with harder cataracts, that's one of the drawbacks that we can't predict it with this formula.
Yeah, I also feel that I agree with him, because
Yes.
as it is, it's a very hyperopic eye, and the space in the anterior chamber is very less. And then you have also exteriorized the haptics of the phakic lens.
In this
So as
particular-
such, there are too many things there which is in a very small AC, where I feel that it could have been a better option to expand the ICL. Maybe in very expert hands it's still possible, where without exteriorizing you can just probably do a phaco by if the space is good. But otherwise I think it's probably prone to more complications.
In this particular patient, the anterior chamber depth was 3.5, sir, both eyes. So there was enough space, and viscoat was used. And also in denser cataracts, another option could be to explant the ICL, do the cataract surgery, and implant the same ICL using this formula. If it's not a dense cataract, if it's just an anterior subcapsular cataract because of the ICL, that could be a good option.
Which company's IOL was implanted in this? Just to know.
IOL was Technis, the Johnson &
Did
Johnson.
you check Indian companies whether they'll make a 45 IOL, power IOL, which will be very, very cheap? If the expense is the cost is the
Yes,
main issue which you have told.
Yes, sir.
Could you check it out?
Yes, sir. At that point, all the companies were tried, and it was properly evaluated and seen that the patient was not able to afford that lens. So,
This IOL was given free of cost to the patient?
sir,
This IOL was given free of cost to the patient?
it was not done free of cost, but it was done at a much lower
but
package.
because the patient was not able to afford the cost, and
Yes, sir.
I think Technis is not a very cheap IOL, and there's I think
Yes, sir.
Oral
It was
Lab,
done at a lower
Appa,
package.
etc., are available.
Since we were able to implant the IOL of a standard power in the first eye, we did it at a much lower package. It was a sample lens that was used also. So it was a lower package that was done. Yes.
Thank you. Thank you.
Thank you, sir.
Dr. Vaishal.
So I think maybe, sir, we can take next, and then I'll.
Shall the presenting author is given as Vaishali here?
Yes, sir. Sir,
That has been informed?
We've written it quite a while ago that I'll be presenting in your
Okay.
place.
Thank you.
So I think maybe, sir, next, and then I'll just reconfirm there's some issue.
Who is presenting?
This presentation is not loaded.
Shaila.
Before he loads, I think next presenter can come up. Dr. Shilpi Arya.
Next one is
Yeah.
Yeah. Next presenter.
Dr.
Dr.
Shilpi.
Shilpi. No.
Shilpi area is Dr. Shilpi. Shilpi is not there.
Dr. Kusumita or Dr. Surya Shekhar have come.
Yeah. Dr. Surya Shekhar is here. Dr. Kusumita Chaudhary. Not there.
We just want to reconfirm the presenter. Dr. Shivangi Singh is there. Shivangi Singh, I think she presented. the
She
first.
presented, yeah.
Yes.
Dr.
And the second was Dr. Paulomi Ghosh. I think she presented also.
Yeah.
She left.
The next two are absent.
Next two are absent. Dr. Kusumita Chaudhary, Dr. Surya Shekhar, they were absent. Absent, okay. And Dr. Nitin Deshpande had presented. Vijay Shetty presented.
So we have to write. Yeah, okay, please.
Vijay Shetty. I think yes, she presented. And next was a non-ratified member. And this Supriya Samak had presented.
Yeah, she presented.
So that means this is also okay. Yeah. He is supposed to present. Dr. Sel, you can present.
Yeah, start off, Chef.
Yes, yeah.
So, can you start the timer so that I can start? Yeah, sure. Very good morning. I'll be presenting on the comparative intraoperative performance using different fluidic systems. This study was funded by Alcon Laboratories. So the aim was to compare the intraoperative efficacy and post-operative safety of active Sentry and the normal Centurion handpiece using different IOP settings to see their outcomes on the clinical patient scenario. We divided the patient into three groups. First group where phacoemulsification using the traditional Centurion handpiece was used with an aspiration flow rate of 40 cc and a vacuum of 500 to 650. The second group was used the same cataract situation with active Sentry handpiece of the Centurion and similar parameters. And the third group was divided into the infinity group or the gravity fluidics. Amongst the two groups, the traditional handpiece and the active Sentry handpiece, we further subdivided the patients into two different IOP settings, that is keeping the flow rate at 40 and vacuum between 500 to 600. In half of the eyes we used an IOP of 30, which is considered to be lower IOP, and in the second half we used 55 millimeters of mercury, and this was followed in both the groups, the normal handpiece as well as the active Sentry handpiece. The CDE and fluid used were the intraoperative outcome measures. The post-operative primary outcome measure was the difference in the CCT from baseline starting from 1 week to 1 month post-operatively, and secondary outcomes were the clarity, cells, flare, so on, and the anterior segment inflammation. When we look at the comparison of the CDE, the active Sentry handpiece had significantly lower CDE as compared to the traditional handpiece of the Centurion vision system. Of course, the infinity fared the worst. And when we come to the mean change in the CCT, when we compared the high IOP, that is 55 millimeters, comparing the two groups, there was no change in the significant difference in the central corneal thickness up to 1 month post-operatively. In the traditional handpiece group, in the post-operative CCT, was significantly less when lower IOP was used compared to high IOP. So in the same Centurion handpiece, when we use 30 IOP, the CCT raise was less compared to when we use 55 centimeter, 55 intraocular pressure. In the active Sentry handpiece, there was no difference whatever IOP we used, whether it was 30 IOP or 55 IOP. When we look at the cells flare within the group 1, that is the traditional Centurion handpiece, they had significant higher incidence of cells on post-operative day 1 in groups A and group B. In group 2, which is the active Sentry group, there was no difference intra-group wise. So there was no difference whether we use 30 mm or 55 mm of intraocular pressure. When we compared the rise and fall is the IOP that was done with the IOP tracing sensors, there was a significantly faster rise of IOP to the baseline following occlusion break in the group 2, that is the active Sentry, compared to when we compared the traditional Centurion handpiece. So the clinical applications of this study would mean that the traditional handpiece had good post-operative outcomes with lower IOP. When we moved the IOP a little higher, the anterior segment inflammation and CCT was higher on the first post-operative week. However, with the active Sentry group, whatever IOP you use, it did not matter even with high flow rates and high intraocular pressure. So, and it also helps in faster surge mitigation. So therefore, I think it will be, you can probably use the parameters of your choice with a low intraocular pressure safely. Thank you.
Shail, one question. What is this traditional handpiece?
Traditional is the normal Centurion handpiece which has the sensor at the cassette. So the active Sentry handpiece has the sensor in the phaco probe itself.
Okay, and why was in group 2 more fluid was used?
So probably what we feel was that probably we were using high and low IOPs along with a very high flow rate of 40 cc. Maybe that may be one of the reasons why more aspiration was being done.
No, but all ranges in 3 handpieces, it was all similar.
Similar.
It was similarly
Similar, but there's no statistical difference. Yeah.